So that's the new one. So hello everyone, and really good to kick off our September webinar series with Dr. George Moncrieff. Many of you I know will have seen him or met him in, I think it's back in January, George, that we had our first webinar together, wasn't it?
It was January or February, yes. Yeah,
where we were talking about steroid cream. Slightly controversial from a medical standpoint, unless you put it completely into context. And I think that could also be said with what we're actually talking about today as well, about sunlight, etc. So I'm very pleased to kick off. So George, would you like to just introduce yourself again to people, just so everyone knows who you are, and then we can talk about what we're going to talk about. And I know we've got lots of good slides to get through. Very quickly, while I'm wittering on, as usual, please do post any questions that you may have as we go along, and I'll pick them up at the end, as long as George allows us time to answer them, I think.
I'll try not to. Okay. Well, hi, I'm George Moncrieff. I was a GP in Oxfordshire and for about 35 years, and retired from my practice, gosh, almost 5 years ago now. I've actually been working back there this last couple of weeks to help out a bit. After I retired, I did work privately in a small practice in North Oxford for a while, but I also handed that in about a year ago. For about 20 years, I ran a community dermatology service from my practice, and about 50 GPs sent most of their patients with skin problems my way. I saw a huge amount of skin disease that way, and I've always had a keen interest in dermatology. I became the curriculum guardian for the Royal College of GPs for 4 years, and then following that I became the chair of the Dermatology Council for England. And more recently I've set up a community dermatology service in Birmingham with a large federation and remain a consultant to them. But most of my time now I spent with my grandchildren and lecturing and doing odd bits of work for colleagues.
What, lecturing your grandchildren, was that? Or just
always lecture my family, yes.
Oh. Okay, so shall we kick off then about sunlight? Sadly, we don't have much, but I think that, George, you're going to cover, in fact, we don't need to have the blaring sun to get the benefits necessarily from it.
Right, can you see my slide?
No, that's it, well done.
Lovely. Good. Well, yeah, you throw me right into another controversial area, Katrina. My views here are somewhat heretical, I think, but I hope you'll bear with me and listen to me trying to give a balanced argument on what is the story about UV light. So I really want to ask is, do the benefits of responsible sunlight exposure, do they actually outweigh the risks? And as you can see from my tan, I think they do. It was only last week when I was back in my old surgery, a colleague said to me, George, why, when you claim to have such a keen interest in dermatology, do you always sport such a remarkable tan? Well, this is me on holiday. And yeah, I go to hot places and I do expose as much skin I think is decent, and try and get as much sun on me as I can without burning. So, but whilst I was out there, I met a dermatologist, also on holiday, and he was taking appropriate cover. That's a joke. That's not quite exactly what happened, but if you listen to what they had to say, you would be wanting to cover yourself up completely. Most dermatologists I speak to, including and politicians, are constantly warning all of us of the serious risks of UV exposure. And you'd have thought we had to sort of closet ourselves in that way with NBC suits all the time. I think the reason they're doing that, why politicians endorse it, is actually not to do with the risks, but because the NHS can't cope with the demand from the consequences of sunlight exposure. But I'll come back to that. Actually, expanding on that a little bit here, over half of all referrals from primary care, from general practice to dermatology, to specialists, are for lesion diagnosis. And there are more referrals to the Skin Cancer 2-week Bureau than any other 2-week cancer bureau. It has a heavy workload dealing with concern about skin lesions. And when I was chair of the Dermatology Council for England back in 2016, I did a Freedom of Information Act report to the All-Party Parliamentary Group for Skin Disease and got a really good response from the trusts. But even back then, 6 trusts in England were no longer able to offer any service for inflammatory skin diseases such as acne, eczema, psoriasis, as they were so totally overloaded with referrals for lesion diagnosis.
Wow.
And in the last 18 months or so, since COVID, things like that have only got worse. It's become, there's some departments that are just absolutely struggling to give any service. Well, there are a few exclusions to what I've got to say today, and one of them includes children under 11. These are 2 of my grandchildren on holiday with us. I think it was in Mallorca. And we keep them in the shade. We keep them in the dark in a number of ways, but we keep them in the shade. I'm going to be talking a bit about blood pressure. I've never seen blood pressure in a child. It does exist, but it's incredibly rare. I'm not worried about blood pressure in children, and we can give children vitamin D. So the main advantages of sunlight are not particularly relevant to children, and I think children under 11 need complete protection. The other groups that I think need pretty seriously complete protection are those who are immune suppressed. If you've got immune suppression from steroids, disease-modifying drugs like azathioprine and so on, or patients on with transplants or HIV, these patients need to be particularly careful, and I'm excluding them from this advice. They need to be protected. And of course, there are some skin conditions I'll be mentioning which are also aggravated. But all these skin cancers are more aggressive in patients with an immune system that's compromised. So we need to be much more cautious with that group. Skin cancer is incredibly rare in people with skin of color. That's they're making a pigment called, they have a type of melanin called eumelanin, which is brown black. The only exception to that is the melanomas that occur on the hands and the feet, under the nails, around the nail apparatus. These are called acral melanomas, and they've got nothing to do with ultraviolet light. Those are a genetic condition, just as common in dark skin as they are in white skin. Bob Marley got one under his nail and he dismissed it. He didn't realize what it was. They're often missed and left till too late. But brown black melanin, eumelanin, stops you getting skin cancer. It's incredibly rare to get skin cancer in that cohort unless they're immune suppressed. So why did our ancestors originally start to evolve to produce melanin? Well, you've got to go back a long, long way. Before 7 million years ago, we didn't have melanin, but we were covered in hair. And around the time that our ancestors became bipedal and started walking, we lost that body hair in order to lose heat and to be able to sweat. But then our skin was exposed, and as a result of that, we needed to protect ourselves. Then about 1.5 million years ago, there was a mega drought. And this drove humans out from the forests into more arid landscapes where they were exposed to the really strong ultraviolet light you have in Central Africa. And that is what we think drove the need for melanin. The earliest reports of man with melanin go back to about 1.5 million years ago from fossils then. And this is what the example that we use that demonstrates that we had the first evidence of eumelanin way back 1.5 million years ago.
Wow.
That was probably driven by the evolutionary pressure from exposure to this Central African strong UV light. But that wasn't due to skin cancer, the need to make that melanin, because it's only melanoma really that kills significantly, and that's pretty uncommon. And it often occurs beyond reproducing age. Risk of spread from other forms of skin cancers like squamous cell carcinoma is really very small indeed. So it wasn't due to skin cancer. It wasn't due to them having too much vitamin D, because that's physiologically impossible from too much sunlight. That couldn't happen. Sorry, what's happened there? Let's go. It wasn't due to sunburn, almost certainly, because that's not going to have a lasting impact on your ability to reproduce. Yeah, it'd be painful for a few days or a week or so, but it's not going to stop you having a family. It's almost definitely due to folate deficiency, because ultraviolet light does destroy folic acid. And that we think is probably the driving factor. But then we're talking about 1.5 million years ago, somewhere between 50 and 200,000 years ago, there's debate over exactly when this all happened. People began to migrate out of Central Africa into more northern and more southern latitudes where the sunlight was weaker. So this all happened around about 1 to 200,000 years ago. And as they migrated away from the equator, there's an evolutionary pressure to lose the ability to make dark melanin. Recent studies have shown that dark skin actually prevailed in Europe until just 9,000 years ago. Now, 1 million or 1.5 million years is 1,000 to 1,500 years. We're just talking 9,000. But strangely, these people had blue eyes. Going back just 5 to 5.7 thousand years, black skin was still normal in Europe. And the transition to white skin took place remarkably fast over just a few generations, just 1 to 3,000 years ago. We're talking about sort of biblical times, not that long ago. Quite extraordinary. It happened very fast, and it happened almost synchronously all around the world. That's astonishing, that need and drive suddenly to stop making new melanin. And we see that the further you move away from the equator, the paler your skin gets, until you get up into Scandinavian countries. You have true Celtic skin, where you're making a completely different melanin called pheomelanin, a pink melanin that doesn't protect you much from the sun, allows sunlight through. But melanin almost completely protects you from skin cancer. So why did we evolve to lose this wonderful protection? Well, it was almost certainly due to vitamin D deficiency. Vitamin D is incredibly important for calcium metabolism and bone health. We all know that. But that's not the end of the story as far as vitamin D is concerned. It has massive roles. It has an influence on our immune system, including the innate immune system. The adaptive is the one that immunizations work on, but we have an innate immune system that vitamin D has a huge role to play there too. It also has a surveillance role. It watches our cells, and it helps our cells that watch cells that become cancerous to get rid of them. It controls that, has a big role there. And it has a role in pancreatic function and protecting you from getting diabetes. So vitamin D has huge metabolic effects all around the body. And the other thing I'm going to be talking about is something called nitric oxide, which is a neurotransmitter, which is involved in your control of your blood pressure, helping to lower it. I'll be talking more about that later. So what are the evolutionary costs of losing dark melanin? There are clearly huge advantages, but what were the costs of losing it? What are the risks from UV light? Well, of course, sunburn. If you get sunburnt, it's pretty unpleasant. And it can be very, very painful, and it can scar. We all know that. It can be really horrible. And the problem with sunburn is it comes on several hours or a few hours after you've been exposed. It's not immediate, like a burn from a scald. If you get burnt in childhood, often in somebody with sort of light skin, it will leave this pigmentary clumping in this sort of pattern. This tells me this patient has had significant past exposure. I saw him just a few days ago. He kindly said I could use these images. He said he was quite badly burned as a child. And episodes of burn,
did he have freckles to start with?
No.
So, oh, right.
If you look at his skin where the sun can't get to, I've got an image that shows that, but I haven't put it on in this deck.
Yeah.
If you look under his arm, for example, there's absolutely no freckle skin there at all. This is all in the areas where he got exposed to sun as a child.
Wow.
And it is episodes of burning, particularly in children under 11, that account for most of our lifetime ultraviolet risk from melanoma. In other words, if you spent your childhood in Scandinavia and then migrated to Australia at 11, you would carry with you your lifetime low risk of melanoma. If, however, you migrated from Australia at the age of 11 to Scandinavia, you'll take with you your lifetime high risk of melanoma. It's the first 11 years and your experience of ultraviolet light in those 11 years that really matters.
Wow.
The main justification for advising everyone to stay out of the sun and to wear sunblock is concern about skin cancer. So let's just have a few words about those. the first recognition that there's a link, there actually is some evidence going back to 1890 that I've found, but the main one that people report is actually this work of Findlay back in 1928. He was the first person who really put it on the map that ultraviolet light can cause skin cancer. So we've known about it now for almost 100 years. Ultraviolet radiation is the most important modifiable factor causing skin cancer, especially in children under 11, especially episodes of sunburn and use of a sunbed. A sunbed does seem to be particularly dangerous. It can be, it's not regulated enough, the intensity of the sunlight, of the ultraviolet light, and you can get quite high doses of dangerous ultraviolet light from a sunbed. I would never use a sunbed. In fact, you can get massive overexposure. It's now illegal. That was work of the All Party Parliamentary Group, 2010. I was remotely involved in that. Past users have a 20% increased lifetime risk of melanoma, and every additional episode of using a suntan increases that risk by about 2% per year. So I just wouldn't personally go to a sunbed at all.
I'm amazed that they still have shops are still available when we've known for so many years. I can't believe that they're not regulated or something.
Well, they are in children under 18, but not in adults.
Yeah.
I agree. I think that they're dangerous.
Mm.
However, more important, that's the single most important modifiable risk factor. The main risk factors actually are the things that I listen to are a past or a family history of melanoma. If someone says my sister had a melanoma, I'm worried about this mole, boy, do I look at it carefully. Mm. If they said I have holidays abroad and I enjoy the sun, I say, okay, let's have a look at your mole. I'm not quite so anxious. And also having multiple moles. If you've got more than 50 moles, and I don't mean seborrheic keratoses, these sort of scaly, warty things we get as we get older, but some people get, I mean moles. If you've got more than 50 moles on your body, more than 20 on one limb, or more than 6 on your face, you've got multiple moles and you are at greater risk. Some people have over 200, like this gentleman. And his moles need to be carefully mapped, because when he gets a melanoma, it's a devil's own job to recognize it, because it can start off looking like one of his moles. It's hiding amongst all the other moles. And so you've got to say, hang on, this one wasn't there before, and it's changed and it's become there. So you need to be careful. But multiple moles is a risk factor. And when you get a melanoma, they can either be the superficial pattern, which are spread laterally and stay fairly flat, or the more nodular patterns, which have a worse prognosis, where they're raised and bumped up. Oh. And the numbers are increasing quite fast, from sort of around 15,000 2014 with 2,000 deaths a year, 42 new diagnoses per day. It's sort of doubling every 10 or 15 years. And we expect it to be about 40,000 per year by 2030. Some of this might be related to lifestyle changes, holidays abroad, spending more time outdoors, and possibly intermittent but intense UV exposure, trying to get your sun exposure all concentrated into just 2 weeks, and accepting the fact you might be burnt during that fortnight's holiday. The number of deaths, though, remains fixed at around 2,000. Treatments have got better, and our ability to diagnose it earlier has got better. So some of this increase might be related to better diagnosis and earlier diagnosis. But it still hits young people. It's a disease that can occur in young people and has absolutely tragic consequences. So I don't want to underestimate the importance of melanoma. But please don't mistake what I'm having to say here to say I don't think melanoma matters. I have had patients who've had melanoma, and it is awful. And the rates are increasing for a variety of reasons, but probably partly due to increased diagnosis, partly an aging population, and partly actually increasing and our lifestyle that we're doing. And
is also global warming change, is that a factor?
I think ozone holes probably are playing a part, yes. And so certainly in Australia, where there's a large ozone thing, and so that's affecting ozone levels, which is very good at filtering out bad sunlight. The other skin cancer that really matters is the squamous cell carcinoma. But actually, if you have a squamous cell carcinoma, the risk of that ever spreading, if you're immune competent, is about 1%. So very low risk of spreading, and it's pretty obvious that what's going on. It's a growing, hard, scaly nodule. The other one is a basal cell carcinoma, and to be honest, they don't bother me a jot. They don't spread, they don't metastasize, or very, very rarely indeed. They grow very slowly, and although they constitute a huge amount of work for the NHS, there are several hundred BCCs for every one melanoma. So there's a vast amount of work there. And leave them alone, they will continue to grow and erode anything in their path. So it's best to get them out. So there's a lot of work dealing with them, but the risk to the patient is trivial. And the other thing, in fact, is interestingly, basal cell carcinomas sometimes occur on completely sun-protected skin. There's an area of skin behind the ear, which is known as Wilkinson's triangle. It's said to look the same when you're 90 as it did when you were 9 or 9 months even. And it's behind the ear, an area of skin that never has had any sun exposure. And that's a typical site for a BCC. So if I'm examining somebody worried that they might have a cancer somewhere, that's one of the sites I always look at carefully. A non-sun exposed area where you still get BCCs. But the thing about skin cancer, unlike ovary, bladder, pancreas, stomach and things, you can see it. It's there, it's in your face, and it's changing. And you can therefore diagnose it early, and you can get it out, and you can be cured, even from melanoma. An early melanoma, cut it out. 6 months later, the scar's clear, you are cured from that melanoma. Whereas ovary, bladder, and pancreas and things, these sneak up on you. They don't produce symptoms until they possibly spread. They're much more frightening and dangerous and difficult. The peak age for melanoma is actually old people, 85 to 89. And all the non-melanoma skin cancers definitely just continue to increase with age. So although you get melanoma in young people, the peak age is in old people, and all the non-melanoma ones tend to be in people who are much older. And so a lot of the rise we're seeing is that we're living longer, and that is having serious consequences. I call it the demographic time bomb. If you look at some of the facts for that, there are 5 times more people alive today in the UK over 85 than there were in 1951. 5 times more. It's massive. And if you look at centenarians, the number of people over 100 in Britain in 2002 was 7,700. By 2012, it had almost doubled. By 2028, it's estimated to be 4 times that. And before I get to 100, wait for it, the number of people over 100 will be 350,000.
Wow.
So if you have one person in a nursing home in 2002, a nursing home with 30 beds, that nursing home will be completely full of people over 100, let alone all the others by 2050. This is frightening. And that's the age group that are getting melanoma. So no wonder we are seeing more. The actual number of deaths, though, from skin cancers in total, including the squamous cell carcinomas, and they're more common in people whose immune system is suppressed, is 3,000 deaths a year. Compare that to deaths from arterial disease, things like heart attacks and strokes. Not 3,000, 200,000 deaths per year. You put it into context, put a little dot. Back in 2011, the number of deaths from skin cancer was that tiny dot there, 2,500, where circulatory diseases was already up to 140,000, 100 or so. So it's, put it into context, it's not a likely cause of your death. There are more deaths.
I was going to say, I mean, that's really interesting to hear that, because you hear so much about skin cancer and all those, and one naturally thinks it's going to lead on to, you know, a death. And you've put it really into context as to...
There are sort of 20,000 melanomas a year and 2,000 deaths. So it's not 20,000 deaths at all. The majority are cured. And there are more deaths due to falls than all skin cancers.
Gosh.
People falling and dying as a result. And I think it's the ability of the NHS to deliver a dermatology service is becoming overwhelmed, is what's driving the panic that we hear about keeping out of the sun. Going back to referrals, over half of the 1 million referrals to dermatology each year in the UK are to the urgent skin cancer 2-week period. I've just said that before. Of these, only 6% of these urgent referrals turned out to be either a melanoma or squamous cell carcinoma, the two that matter.
Wow.
94% of patients who are referred to the skin cancer 2-week wait have a benign lesion. So I think we're not doing our job well in primary care. That's the problem. If that is our hit rate, it's appalling. And that's what's overwhelming the system. And that's what's driving the British Association of Dermatologists to come up with things like cover-up mate. And the practice in Australia of slip, slap, slop, which has been running now for 30 years or so, and has resulted in a reduction in the number of skin cancers, particularly melanoma. It is reducing the number of people who have that. So it does work. The other risks, so that's skin cancer. The other risk is the aging changes caused by UV radiation, including freckling. You go out in the sun, you will freckle if you've got light skin. If you haven't got the protection there, and that's a marker of future sun-related skin problems like skin cancers. This young girl will have problems in the future because of her childhood exposure and her freckling. Here's a patient rather similar to the chap I showed earlier with freckling on the forearm there, but if you look at the inside of her arm, that's what her skin looked like without the effect of sunlight. She's got type 1 or Celtic type skin. She freckles. And there's an older person with more freckling. This is a marker of UV damage. Sometimes you can get age spots or liver spots. So the proper name is solar lentigo, perfectly benign, flat, sort of almost like a watermark, brownish tan coffee colored lesion on the face or some exposed area. Wrinkling is aggravated by sunlight. This is a lady she's Turkish but was brought up in the UK and has spent her life in the UK, and her identical twin sister continued to live in Turkey, and that is the effect of sunlight.
Wow.
It's just where she'd happened to live. Just the difference, but she looks 10, 20 years older, doesn't she? And then there's a condition called solar elastosis, which is sort of extension of wrinkling, where you get this elastotic-y material, this yellowy material under the skin as a deposit in response to ultraviolet light. Interestingly, if you form solar elastosis, you are less likely to get a BCC, and you're less likely to get an invasive melanoma. It is somehow the people who have the response to ultraviolet light that causes solar elastosis are protected from getting melanoma to some extent. So although it's a marker of sun damage, it's not necessarily bad news. And then of course you can get these, I think, completely benign lesions called actinic keratoses, which are scaly, rough patches on sun-exposed skin, which I don't think are of anything other than a marker of sun damage. I don't think they have to be treated. They're a cosmetic issue. The risk of those progressing to skin cancer, I think, is vanishingly small or non-existent. Of course, a squamous cell carcinoma, squamous cell cancer, starts off life looking like an actinic keratosis, but 2-3 months later, it's declared its true identity and it's growing and becoming raised. These remain stable, and a quarter of these disappear on their own. So I'm very relaxed about actinic keratoses, but the whole profession as a group is not particularly, and they tend to want to treat them. But I think that I'm treating them for cosmetic reasons. All of these things, freckling, wrinkling, solar elastosis, solar lentigos, actinic. Actinic just means from the sun. So some we call them solar keratoses. I think these are all these are cosmetic concerns, and I think the lifestyle choices. Then there are some skin conditions which are very definitely aggravated by sunlight. Examples would include, well, many conditions are made worse, and about 10% of the population do have a UV aggravated skin condition, such as prickly heat. Proper name is polymorphic light eruption, commonly a problem in the spring, when you first go out into the sun, and before your skins become more tolerant to the sun it's lost its tolerance over the winter. You get this itchy, bumpy rash that comes out when you come out of the sun, very nasty. Or melasma, very definitely, this pigmentary change on the face, very definitely aggravated by sunlight and female hormones. condition I see a lot called poikiloderma chivati, where there's a sort of pigmentary change, most commonly on the side of the neck here, triggered by sunlight, but it's almost certainly that sprays from a perfume, a fragrance, makes the skin sensitive to sunlight, and that triggers this change, commonly seen in women in their middle years, this sort of slight sort of redness and pigmentary change on the side of the neck, poikiloderma chivati. Rosacea, unquestionably, the most important trigger that aggravates that is ultraviolet light. And then there are other conditions more rare, like lupus, which are very definitely photo-aggravated. And then a lot of people take drugs that are photosensitizing, from retinoids to certain antibiotics and so on. Lots of drugs can cause the skin to become more sensitive, and we need to be careful with them. Lime juice is something that lots of plants can leave psorolens on the skin that make the skin super sensitive to sunlight and cause a really nasty dermatitis. Lime juice is probably the worst. And if you spill lime juice on your skin when you're in a sunny environment, wash it off and get out of the sun fast, because you can get a really, really nasty phyto, meaning plant, photo, meaning sunlight, dermatosis. It can be very aggressive. So lime juice in the sun is bad news. And of course, ultraviolet radiation can cause other things like cataracts and age-related macular degeneration. So our eyes need protection. Those are the costs of ultraviolet light: sunburn, skin cancers, skin aging, photo-aggravated skin conditions, cataracts, and so on. Those are things we need to be aware of if we're going to go out in the sun. Just a bit of sort of words about ultraviolet light. Ultraviolet light sits next to visible light in the electromagnetic spectrum. We have UVA right next to visible, and then narrow bandish of UVB, and then UVC is not really relevant. It doesn't get through our atmosphere. So it's UVA and UVB that we mostly talk about. And the intensity of that depends on a huge number of factors. How high the sun is, that depends on the season and the time of the day, the latitude, cloud cover, or whether you're indoors behind glass. Altitude, if you go up skiing, you're more likely to, or go up a mountain, you're more likely to get sunburnt. Every 300 meters, it increases by 4%. Ozone, which we've just mentioned. Reflection from sand, snow, and water. Shade, and so on. Lots of things affected. And of course, your sensitivity to sunlight depends on your melanin, depends on your skin type. UVB burns. It's 100 times more burning than UVA. That's the one that causes the burning. It's almost completely filtered by cloud and by glass. We all know that if you're indoors, even in the conservatory or in your car, or on a cloudy day, you're not going to burn. And UVB doesn't really penetrate very far into the skin. It's filtered in the top layers, so it doesn't get down to cause much damage deeper in the skin. So UVB can burn, but it doesn't penetrate. And the intensity of UVB, actually, interestingly, is at its peak in the Northern Hemisphere on June the 21st, and at its weakest around Christmas Day. And therefore, the intensity is equal on March the 21st as it is on September the 21st, or sorry, April the 21st and September the 21st. Those are the two equinoxes. So people often worry about the sun in September or early September, like now, but they forget actually that late April, it's just as strong. And because the temperature of the atmosphere is less, people are less concerned about the sun then, but it's just as strong in April as it is in September. UVA doesn't burn. UVA ages. It's right next to visible light. So if you can see the colors of the rainbow, if you can see blues and reds and oranges and things, you're getting UVA. And just as visible light goes through glass, just as visible light on a day-to-day when it's cloudy goes straight through cloud, UVA goes straight through cloud. It's barely touched by ozone. And it barely changes throughout the day. It's just as intense in the morning as at noon as at night. And it's just intense in December as it is in June, or not quite, but its intensity barely varies, just as visible light barely changes with the seasons. And it penetrates deep into the skin. 50% gets right down into the deep layers of the dermis. And it's there that it causes the dermal changes and causes the aging problems. It's a penetrating ultraviolet light. Most doctors say when you've got a suntan, you've got evidence of sun damage. I disagree. As you can see from looking at me, I think a suntan is healthy, but it must not be acquired at the expense of getting sunburned. You've got to do it gently and carefully. When melanocytes are exposed to UVB, that stimulates them to release little packets of melanin called melanosomes, and it stimulates them to make more melanin. And that results in a deep, lasting tan. Now, this is incredible. That's an image of a melanocyte with long arm-like processes, finger-like processes, which communicate with every cell in the skin. And down their arms go these little packets of melanin, which are taken in by those epidermal cells, the cells on the surface of the skin. They then release those little the melanin from those packets. And this is the really clever and amazing bit. They then deposit it as an umbrella, wait for it, on the outer surface of the nucleus.
Wow.
Acting as an umbrella, protecting the nucleus from UV radiation. Astonishing.
Mm.
And the UVB stimulates them to make more melanin to replenish that. UVA does cause release of melanocytes, to melanosomes from melanocytes, releasing melanin, but it doesn't stimulate the further production. So you don't get a lasting tan, you just get a brief tan, which won't last for more than a few days. It's UVB that gives you this lasting tan. Now, the crafty thing about that is it means that your cytoplasm, which is not at risk of damage from UVA, is in the cytoplasm, in the cell material, not the nucleus. The nucleus is now protected. The cytoplasm of that cell is still exposed to ultraviolet radiation. It's there that you make vitamin D, and it's there that you make nitric oxide. Until about 40 years ago, we had no effective sun filters. I remember as a child, I just basted myself with oil. We didn't have anything that filtered ultraviolet light. The early sunblocks only filtered out UVB and stopped us from burning. So we thought, wonderful, we can now stay out in the sun as long as we like, and we did, and we didn't get burnt. But we ended up getting massive doses of UVA, huge exposure, which wasn't burning, but was probably causing quite a bit of penetration of ultraviolet light and causing some damage. However, there's very little evidence that even using effective sunscreens that block ultraviolet light protect from skin cancer.
Wow. Yeah.
Exactly. The main study quoted, and the only random control trial, was the NAMBA trial. And they said sunblock offered no overall protection from melanomas. There were a few invasive melanomas, but it wasn't a massive change. Now, that's not for me to say to you, don't go and use sunblock, because it will stop you from burning. Put this in some other context. How many melanomas could we prevent if more people applied sunblock properly? And very few people do use it properly. You've got to really use 2 grams per, 2 milligrams per centimetre square. It's quite a lot.
I think that's always the problems with creams, isn't it? Whether it's you're treating it because you've got eczema or psoriasis, or just sun cream. There never seems, you need to have, I think, a diagram to really show you how much you're talking about.
Generally speaking, what we say is that all these tubes, except that sunblock often comes in bottles and things like that, but all tubes of creams come with a 5mm nozzle. Every single one, whether it's a tiny tube or a big tube, they all have a 5mm nozzle. And if you squeeze that cream or ointment out from the last crease on your index finger to the tip of your finger, that's called a fingertip unit. And that's almost exactly 0.5 gram. And 1 fingertip unit, 0.5 gram, should cover the area of skin of 2 palms. So that gives you a feeling for the quantity of creams and ointments that we expect people to use when they use a cream or ointment for therapy. So that's the volume that covers 2 palms. But if there's a 5% increase in skin cancer, in skin sunscreen use over a 10-year period, it would give a 10% reduction in melanoma. Okay, it's not that massive, is it? You would have thought we're talking about huge increases. Put it another way, if everyone used total sunblock all the time, we blocked sunlight completely, the number of melanomas in people with white skin would fall by about 34 to 38%. In other words, 60% would still occur. So it will make a difference, but not a massive difference. Let's think about some of the benefits of sunlight. Well, this is Freddie, my grandson, on holiday in Corfu at the end of the holiday. And you can see he's had we were reading him a story in the morning, his parents were still asleep, and he'd had no significant sun exposure. He has been completely protected. Non-burning activities, he was doing a lot outside, so he was completely protected, are associated with a reduced lifetime risk of melanoma, interestingly. But you want to make sure you don't develop in a child any sun tan at all. Lots of skin conditions are treated with sunlight. I mentioned the ones that are made worse by it, but psoriasis, eczema, that light eruption I showed you, you actually use light treatment to build up the tolerance in the skin, is treated with ultraviolet light. Acne is improved, a number of conditions, but hair is very carefully controlled and gradually built up with no burning. Here's psoriasis. I think this is an amazing picture. It shows psoriasis in the area of skin that's covered, quite severe psoriasis. But in the area of skin that's not covered, natural sunlight has cleared her psoriasis almost completely. Yes, she's got some pigmentary changes there. On the covered skin, it hasn't got those pigmentary changes, but there you can see the benefit of sunlight. Yeah. Sunlight also releases beta endorphin. It's a natural opioid. And we've actually used ultraviolet light to relieve the pain some patients have with fibromyalgia. It also enhances the release of serotonin in the brain, which improves mood and reduces anxiety. Remember, seasonal affective disorders associated with the long winter nights and reduced light exposure. So it has these sorts of benefits as well. What about vitamin D? Well, I've already mentioned a bit. Most of it comes from our skin, and you need UVB to produce vitamin D. Interestingly, and slightly worryingly, UVA destroys vitamin D more than it produces it. In the winter, our levels drop by a nanomole per litre every week. So I commonly see people whose vitamin D level is only about 30 or so. But by the end of the winter, they can have undetectable vitamin D levels unless they do something about it. Children who spend long hours indoors need vitamin D. The elderly, they generally cover up more, often don't go out. In a nursing home, often spend their time indoors all the time. They're getting no vitamin D naturally, and very little of their skin gets exposed. And those who live in temperate climates with dark skin and are fully covered, they're going to end up with severe vitamin D deficiency. If you look at the percentage of people with vitamin D deficiency, you can see that it's right up to sort of 70% or more in the winter, almost across the whole of England. And it remains like that into the spring in Scotland and various parts of the country. It is a significant public health problem. And we don't see so much rickets nowadays, but we do see an awful lot of osteoporosis and osteomalacia. And this is all due to lack of vitamin D.
I was going to say about rickets because, when I've been to the Caribbean, for example, there's a lot of rickets there in the elder population, which I found amazing because they're getting the sunlight. So there must be something else they're not getting.
Do you know it's rickets?
Well, they look like that. So I've always assumed that they were rickets.
If they're older people, it could be Paget's, it could be other skin, other bone conditions. It doesn't
necessarily
really. Yes, I'm not. Yeah,
oh.
I'm very surprised by that. I have to find out what was going on there.
Yeah.
But look at this. Several cancers are associated with low vitamin D: lung, breast, kidney, bladder, gut, endometrial, ovarian, and so on. The list is increasing all the time.
Gosh.
A large-scale placebo-controlled trial from Germany showed that giving vitamin D reduced cancer risk by 60%. Putting that into population terms, that means that if vitamin D was given to everybody in Germany, there'll be 30,000 fewer cancer deaths every year. Vitamin D is critical for cancer cell surveillance. It's needed. It also affects all parts of the immune system. I've just said it controls cell proliferation, the way in which cells divide and mature, and it's involved in the destruction of early cancer cells. Vitamin D is involved in cognitive function, and using vitamin D reduces the risk of dementia. And tumours depend on having a rich blood supply. So one of the first things that tumours do is they improve the blood flow to those abnormal cells. Vitamin D prevents that. It's anti-angiogenic. It starves the tumours of their blood supply. High levels of vitamin D have been shown to reduce the severity of respiratory infections, including COVID-19. As a result of that information, I've been taking high doses of vitamin D, as my wife, since the beginning of this pandemic.
So do you take vitamin D all the way through the year now?
I do actually, but I take even more in the winter.
Right.
The trouble with that study is it's possibly confounded because vitamin D levels are lower in those who are already most at risk from COVID. So if you look at people with dark skin, the elderly who cover up and don't go out so much, people who are overweight, these individuals have low vitamin D levels. And these are the individuals who are at greater risk of COVID-19. So there's some question as to whether it's cause and effect, but we know that low vitamin D levels are associated with a higher risk of dying from COVID. Multiple sclerosis. If you look at France, the number of rads of radiation hitting the south of France compared to the north is 4 times more. The prevalence of MS in the north of France is 4 times higher than the south. Come across the Channel, it's even higher. It goes from 25 in the south of France to 100 in the north, to 112 cases per 100,000 in South England. And by the time you get up to the north, Orkneys is up to almost 200 per 100,000 population. So the further north you go, the more less ultraviolet light you get, the more MS we see. Yeah, just said that. And it's related to a number of vitamin D deficiencies. Interestingly, things like melanoma is associated with vitamin D deficiency. Now, maybe if you've had one melanoma, you now protect yourself from going out in the sun and you become vitamin D deficient. So it could be a confounding factor. But we also know that melanoma rates are rising mostly in people who stay indoors and have intermittent UVB rather than developing a tan like I have and constantly remain exposed to sunlight. But it's also related to other things like autoimmune skin disorders, acne, atopic eczema, and psoriasis. Take atopic eczema. Many patients with severe atopic eczema have very low or undetectable vitamin D. And their eczema if you give them vitamin D, their eczema becomes much easier to manage. I now give vitamin D to all my patients with bad atopic eczema.
Funny enough, I was going to say, do GPs generally, when they see eczema, because eczema is obviously one of the biggest things, they're not prescribing vitamin D?
No, they're not. It's not in their repertoire, no.
Wow.
And suberythema, which means non-burning UVB exposure. Actually, we use light therapy to treat eczema, but you can go out in the sun and get natural sunlight, a bit of UVB, and that'll actually enhance and strengthen the skin barrier. So I go out of my way to talk about that to my patients. Vitamin D analogues, topically, that's vitamin D-like products, have been used to treat psoriasis for years now. They were originally researched as a treatment for osteoporosis, and they just surprisingly found that patients being given these, their psoriasis got better. This is a young woman who came to see me with relatively mild-ish psoriasis on the front of her knees and on her scalp. I gave her a vitamin D product, vitamin D topically with a topical steroid in it in a foam. And within 4 weeks, it had completely disappeared. She'd had psoriasis for 20 years.
Goodness.
Vitamin D is brilliant for psoriasis.
And obviously, we haven't even spoke about the mental health issues that go along with so many of these conditions as well.
Exactly, no, exactly. So low vitamin D is associated with cancer, arteriosclerosis, multiple sclerosis, chest infections, the list goes on, dementia and so on. So why does it have such far-reaching effects? Well, vitamin D is made from this cholesterol molecule. You can see how it's adapted. It's just adapted a bit. Ultraviolet light's involved in that process along with the liver and the kidney to produce vitamin D3. It's just a modification of the cholesterol molecule. Now, cholesterol is the precursor that makes your steroids. So these are steroids, the different steroids our body uses, sex hormones and corticosteroids and so on. They're all very, very similar to cholesterol and to vitamin D. And just as steroids go around the body having dramatic effects, changing us into men and women into women and all the other secondary sexual features and all the critical involvement that steroids have, well, vitamin D goes around the body. It's the same sort of molecule. I've already said that BCCs are very common, probably over 500 BCCs for every one melanoma. But BCCs and squamous cell carcinomas are incredibly unlikely ever to kill you. The only one that matters is the melanoma. A study in the British Journal of Dermatology showed that if you have a non-melanoma skin cancer, and I tell my patients when I say to them, this is what I think you've got, the good news is that is associated with a 3 to 5 year longer life expectancy than somebody who hasn't had the advantage of having a non-melanoma skin cancer. Wow, that's pretty fantastic, isn't it? Now that may be confounded that those individuals whose lifestyle enables them to have enough sunlight to get a non-melanoma skin cancer is a lifestyle that's associated with longevity. But whatever, having a non-melanoma skin cancer is associated with a 3 to 5 year longer life expectancy.
What, just across board of everybody? Yeah. Wow.
Yep. It's a study of 700,000 patients.
Yeah.
Now, the World Health Organization in 2016 said that blood pressure is the single most important modifiable risk factor affecting the human race. More important than immunizations, this was pre-COVID, more important than clean water, smoking, or obesity, blood pressure. You're 65 times more likely to die of a heart attack or a stroke than skin cancer. 65 times. I gave you the deaths earlier, 170,000 deaths per year in the UK from strokes and heart attacks, 2,600 deaths from skin cancers, many of them in immune suppressed individuals. Does ultraviolet light protect against these? Well, when you're in the sun, your blood pressure is lower. And the closer you are to the equator, the lower your blood pressure. And the blood pressure is lower in the summer by 6 millimeters. It isn't just while you're out in the sun, it has a legacy lasting for several hours after being out in the sun. And of course, many healthy lifestyle activities are outdoors as well. Giving vitamin D doesn't lower your blood pressure, but having a high vitamin D is a surrogate marker of sun exposure and maybe a surrogate marker of the protection you're getting from being in the sun. These three guys are amazing. Back in 1998, these three professors were awarded the Nobel Prize for Physiology and Medicine for discovering the critical role of nitric oxide as a signaling molecule in the cardiovascular system. Nitric oxide releases a crucial cell messenger called cyclic AMP. Now, stick with me. That lowers your blood pressure. That is broken down by an enzyme called phosphodiesterase into an inactive product. Phosphodiesterase is inhibited by Viagra. Viagra was originally being researched as a treatment for hypertension by increasing the levels of cyclic AMP by preventing that being broken down. But it needs the nitric oxide. While they were doing that study, looking to see how much it lowered the blood pressure, patients were reporting some interesting side effects, and that's what we now use it for. The main source of nitric oxide is the skin, and it needs UVA. And UVA causes the production of nitric oxide and the release from the stores. But it's very unstable, doesn't last for very long. But it does lower your blood pressure and it increases the cyclic AMP levels. Nitric oxide also switches your white fat to brown fat, which keeps you slimmer and is metabolically active. You can get a tiny bit from lettuces and quite a lot from beetroot. So isn't it interesting that our Olympians back in 2012 knew about this and were drinking so much beetroot that the urinals in the Olympic Village were running red because of the amount of beetroot they were eating.
Gosh.
Nitric oxide almost certainly is the link that accounts for the cardiovascular, the heart attack and stroke benefits of sun exposure. Now, if you cover your skin with sunblock, you're preventing that sun getting to the cytoplasm of your cells. Yeah, you're not going to burn, but you're covering yourself. Great. Unlike the natural sunblock, which has formed that umbrella over your nucleus and enables you to continue to produce vitamin D and nitric oxide. The important thing is never to get burnt. I'm not going to go into this in detail. I think I'll skip through this because I'm running out of time.
I was going to say, because we've got a couple of questions, so.
I'll skip through the sunblocks slides and the ones I recommend. The main justification, staying out of the sun, is skin cancer. As I said that before. So although melanoma is a devastating disease, and I take it very seriously, the actual risk of developing one is very low unless you're in a high-risk group, family history, past history, multiple moles, burnt as a child, use a sunbed. The additional contribution of developing a melanoma from non-burning UV light in adult life, I think, is relatively minor. It's not a big risk. The other skin cancers really don't worry me, provided I remain immune competent. So if you become immune suppressed for whatever reason, then they are more serious and you need to be a bit more cautious. And then finally, don't forget, skin cancers are visible, so it should be possible to diagnose those early and don't need to worry. So when my colleague said to me, why you go around with sporting such a remarkable tan, I said, it's because I have such an interest in dermatology. I don't cover up. I don't wear a hat. I don't keep in the shade, and I can't lather myself in sunblock. That's recommended by all my dermatology friends for four main reasons. Evolution doesn't do things without a reason. Why did my ancestors evolve to stop making a highly effective sunblock when they migrated to latitudes with weaker sunlight? Because the benefits exceeded the risks. Your blood pressure is lower in UV with UV exposure, and I like the sound of that. Skin cancers are not that common, and they should be easily diagnosed. They're visible. Diagnose them early, treat them, get on with it. And at the bottom of the day, I'd far rather have a skin cancer than a stroke or a heart attack. That's what worries me 65 times more than getting a skin cancer. So never get sunburnt. Children under 11 and immune compromised need to have total protection, as well as those with sun-aggravated skin conditions or using medication that makes them more sensitive. Remember, UVA will age your skin, and the price I'm prepared to pay is I'll look older, like that lady from Turkey. But I will be careful not to burn, and I will use enough sun to build up that tan, a nice permanent tan, which will then enable me to go out in the sun and enjoy more sunlight without burning, because I'm not damaging my DNA in my nuclei, and I can get plenty of vitamin D and plenty of nitric oxide. Remember, very few cancers will kill you, skin cancers. So sleep well, and don't forget the sunblock. Don't forget the sunglasses. And
just very quickly to say that as we both discovered on Sunday, I think it was Sunday, wasn't it? Michael Mosley was on Radio 4 or BBC Sounds talking about exactly the same thing, but not giving us such an interesting history lesson. He made it much more accessible. He wasn't quite so scientific. He didn't bombard the public with quite so much science. So I hope you'll forgive me being quite so scientific about it. But in fairness, he had such a much shorter period. But one thing that I did learn and take away from what he said was the fact it's not just, it is exposing not just your face or just up one arm. He was quite, which is what you said, is you expose as much as your body as. Well, you know what? I think in many ways, I think we should be exposing those parts of our skin we've never exposed before. But I think everyone will run away in shock and horror if I did that. Exactly. But yeah, there are parts of my body that have never seen the sun. And why hasn't that skin done its work in the last 60 plus years? So yeah, I think my head and my face and my arms have already done more than a lifetime's worth of work. And I think the underside of my arms and my other areas of my skin could well do with having a bit more sun exposure. But of course, you've got to be careful with those. They haven't built up tolerance to sunlight, and so they need to have their tan built up gradually. Yeah, absolutely. And the one thing that we'll whiz through we've got two questions here. But one of the things that we haven't said is actually the real feel-good factor, that just the feeling of a bit of sun on your back or on your face is just huge, and particularly now when we're all so fed up with what we've been going through. And that's almost certainly due to release of beta endorphins and also serotonin. The main class of antidepressants we use nowadays are the selective serotonin reuptake inhibitors, the SSRIs. Serotonin is released, but it's rapidly retaken back up again. But if you can keep the serotonin levels high after it's been released with these antidepressants, you improve mood. Well, sunlight increases the release of serotonin. So, and I mentioned SAD as well, almost certainly due through serotonin, I suspect, and also beta endorphins. Yeah, we all feel good when we're being in the sun, and I think that's lovely. So, right, whizzing through the questions. I was under the notion that if your skin doesn't colour in the sun, then you're not absorbing vitamin D. So if children do not develop a mild change of summer colour, then are they not getting vitamin D? Then are they getting vitamin D?
Yeah, both producing a tan and producing vitamin D are driven by exposure to sunlight. So I suppose if a child hasn't developed a tan, then you could surmise that they probably haven't made that much vitamin D in the skin. But I'm not worried by that. I think we can give my grandchildren take vitamin D by mouth.
Right.
So I think children under 11 should not be expected to produce their vitamin D through sunlight, but through diet. I think that's the safe answer. I think I'm answering the question. If you haven't developed a tan, then you probably haven't produced that much vitamin D. Because everybody's different, and somebody who's got Celtic skin may never develop a tan. They'll just freckle and burn. They have to be very, very careful. Somebody with more Caucasian, sort of Caucasian skin, from the Mediterranean, they will tan very easily, and they need more sunlight because that's they can tolerate more sunlight, and they can probably take more sunlight.
Okay, next one, last one. How can you measure your own vitamin D levels?
I don't think you can. I haven't measured mine, but my wife and I are both taking industrial doses of vitamin D. Have done since the beginning of COVID. I always took vitamin D anyway, but at the beginning of COVID, I zapped it right up. We're taking about 3,000 units 4 times a week. It's roughly 2,000 units a day. In the summer, I drop it down a little bit. I think anything over 400 units a day is adequate. But in the winter, I would definitely double that. And personally, I like to walk around with it. I spoke to a professor of biochemistry some years ago, and I said, he dealt with patients with vitamin D problems? And that was his life. I said, are you seeing a lot of vitamin D intoxication? Because we were taught about that at medical school, to watch out for having too much vitamin D. I said, have you ever seen it? He said, yes, I have actually, once. And there's a woman who'd been given ridiculous doses, 1 million international units over a very short period of time. He said it just doesn't exist. And I speak to rheumatologists and other professors of medicine, and most of them are taking huge doses of vitamin D, as am I.
But you can, I'm sure that I remember speaking to someone about that. You could take vitamin D, you could actually probably take 1 or just 2 pills a month, which are high dosage.
Yes, yep.
Which are fine for you, but it's just we don't feel we're getting the benefit because we're so in tune to physically popping a pill a day or something.
A rheumatologist I spoke to, he has 25,000 units every 3 months. He gives himself an injection, 25,000 units every 3 months.
Yes, that's it, an injection, yeah. Yeah,
which is a very reasonable way of doing it if you want to. I just take a pill in the morning with my breakfast.
Yeah. And then, so one more has just slipped in. Would vitamin D be in supplement form? Any recommendations? So
I just go on to Holland and Barrett. I go for vitamin D3. And personally, I buy the 3,000 international unit tablets. And my wife and I have those on Monday, Wednesday, Friday, and Sunday. That's how we remember it.
You know, I don't know a webinar, to be honest, that we haven't mentioned how good vitamin D is. I mean, the positive thing is that we do talk about vitamin D a lot.
But it's not just vitamin. Vitamin is not just your bones, it's cancer. It's all the immunity, it's pancreatic function, it's Alzheimer's. And it's not just vitamin D, it's the nitric oxide story, which I think is fascinating. And blood pressure and arteriosclerosis frighten me far more than skin cancers, because if I get a skin cancer, I'll be able to diagnose it. And you diagnose it early, cut it out, it's not going to cause you any problem at all. It might be a lot of work for the NHS. If I was a health minister, I would not want this advice to go out, because there'll be more people getting more skin problems, which will need to go to dermatology, and they can't cope.
Yeah.
So it's not good news for people who are responsible for delivering a health service. But for the individuals, not having strokes and not having heart attacks and living longer may also not be good news for the politicians. But us living longer is quite nice for us. Especially
and I have to say, it's made me want to just whiz out even more to find some sun somewhere, you know, and hopefully next year it'll be much easier, more accessible to us to actually go away.
So this is why I can claim to have an interest in dermatology despite sporting a pretty good tan.
Yeah, no, it's very impressive. I look very PD-bolly compared to you. So on that note, we will wrap up, George, if we may. It's been a pleasure as always. And as you know, the most important part of our webinars are that we record them for people to see throughout the year. And I'm sure that this one is going to be, of real interest to people when they actually understand what we're really talking about. So we're not really talking about this, we're talking about the power of how much your body's health is improved by the sun and the vitamin D that we get.
Very simple thing to do. Just don't burn.
Don't burn.
And if you get a lesion on your skin that is growing or changing, getting bigger, doesn't look like anything else on your skin, for goodness sake, you go to a doctor who takes it seriously.
Yeah, super. Thank you very much, and thank you everyone that stayed with us, and see you next week. Thank you. Bye.
Thanks, Katrina.
Bye.
Bye-bye.